Start with the second session, and our first speaker is Dr. Paul Robertson. I met Dr. Robertson first in the 1980s when I was a fellow at the University of Minnesota. He by then was already the chief of endocrinology, a distinguished professor, and he did studies in pancreas and islet patients that I hadn't even heard of before. And he was working with his team of fellows from all over the world, really, at the CRC at the time. And many of the things that were generated in the 80s and 90s in Minnesota really were the basis and foundation for our current understanding of islet and pancreas transplantation. And when we talk about islet transplantation, meaning both auto and allo-transplantation. Obviously, I mean, he didn't sit still. After he left the University of Minnesota, he became the president in the Seattle area, where he used to work also as a faculty member at the University of Washington. He became the president and CEO of the Pacific Northwest Diabetes Research Institute for 22 years, for a long time. He traded in the Minnesota cold for the Seattle rain, but I believe, all in all, he enjoys the rain better than the cold, Paul. I hope that is fair to say. Dr. Robertson has an extensive bibliography with over 400 peer-reviewed publications in some of the most prestigious journals that exist, over 300 published abstracts. He consistently has received NIH support and grants from other prestigious federal and non-federal institutions. As I said, he has been the mentor and teacher to many endocrine fellows that are now themselves in leadership positions throughout the country and outside of the United States. He was the editor-in-chief of Diabetes for almost half a decade, and also the editor-in-chief of other journals. But he will be probably most recognized for his work in pancreas and islet transplantation, because I think it's fair to say that no one else in the endocrine field has taken that type of interest in what started in the 1970s in Minnesota. And Dr. Robertson, along with his predecessor, Dr. Frederick Goetz, really put Minnesota with David Sutherland on the map in terms of what our current understanding of this type of beta cell therapy is. So I'm very much delighted to welcome Paul Robertson to us today, and he will talk about endocrine function and metabolic outcomes in islet and pancreas transplantation.
Well, thank you, Rainer. It's just a pleasure to be here and see all you folks following carefully what Rainer's doing. The purpose for me to be here is just basically retrace a lot of the things you've heard this morning, but from a metabolic point of view. So it's been my pleasure to inherit the patients that have been transplanted by the surgeons, and then to ask the question, what were the outcomes metabolically? And it worked great. So beta cell replacement, this is just a primer from what you've already heard, just to remind you that there are many ways to replace the beta cell. There's pancreas transplant, partial pancreas transplant, pancreatic islet transplant, and with the subgroups I'm showing you. So many of the generalizations do hold, but there are subtle differences between how much pancreas you put in, how many islets you put in, and where you put the islets, I think, more importantly. So those are some of the things I'll touch on. So let's look first at pancreas transplant. The success rates in terms of beta cell function, alpha cell function, and secondary complications. Now, to be thorough, I should remind people that the beta cell makes insulin, the alpha cell makes glucagon. There may be people here who don't know that. And the secondary complications that I'll talk about are the ones that were mentioned earlier. The tissues get adversely impacted by hyperglycemia. So pancreas transplant, typically the donor, the brain dead donor who donates that pancreas, gets the pancreas put into the recipient's pelvis. The native pancreas is left alone. Most commonly, this is done in combination with a kidney, so the SPK, simultaneous pancreas and kidney transplant. This is an older slide that shows the exocrine drainage from the pancreas going into the urinary bladder. Things flipped in favor of the bowel now, so now the exocrine drainage goes into the bowel, so that both tissue types in the donated pancreas is used. Survival rates. So these are survival rates, both of the patient and the organ. SPK, PAK, and PTA were the three different types of pancreas organ transplant: simultaneous pancreas and kidney, pancreas after kidney, or pancreas alone. Survival rates for the patients are shown in red and green, and it's always been about 95%. I mean, some patients do die, but it's usually not of the surgery. It's a perioperative death. It's probably due to the diabetes more than anything else, because in a long period of time, it would not be surprising to see 5% of a diabetic population dying. So we don't think this is a killer operation. In terms of the organ survival, it's best if you give a simultaneous pancreas and kidney. It's not quite as good if it's a pancreas after kidney, and not quite as good PTA. There are reasons for that that are speculative, but probably not important for us to get into today. But it's very good. If you can transplant an organ and have it be really active out to 3, 5, and I'll show you some 10-year data soon, that's considered very successful. Over time, of course, success has increased. This is a comparison on a slide given to me by Andy Pilsett. If you look at 120 months post-transplant, 50% survival is shown by the gold bar. That's 1987 to 93. There's a light blue one there. It's a little above that. There's kind of a, I don't know what color that is, pink and red. So it even continues to improve today. And I think there'll be more comments later in these talks about where survival is for organ transplant in terms of longevity. Fasting glucose levels. This was the most impressive slide when we got the data back that I can imagine even talking about. These are fasting glucose levels. Of course, pre-transplant, they're all very elevated, but they just drop like a rock. If we had 6 months data, this would be showing that the levels get into the normal range immediately. It's just amazing that you could take a group of patients with type 1 diabetes. This is their glucose control, and if you transplant a pancreas successfully, you wind up with really normal glucose levels. To me, the most impressive comparator for the recipients is the hemoglobin A1C levels as reported by the DCCT. This is a long-term diabetes control trial, and it comprised of a standard therapy, what we called at that time intensive insulin therapy, and we were delighted when we got levels of 7 by treating people more intensively with insulin. Well, here comes pancreas transplant on the scene, and it does much better than we can do with all the tricks we can imagine by giving insulin therapy. These are older data, 1991 comparison for the DCCT. I think with today's therapeutic methods, which have improved, that we can get levels even lower than this. But the price of it, unfortunately, in a type 1 diabetic, if you get lower hemoglobin A1C levels to the normal range, you're also going to get hypoglycemia. We don't want that. That's more dangerous than the difference between 7 and 6 for hemoglobin A1C. So most of us treating patients are very happy if we can get them at 7%, particularly as the patients get older. It's just not safe to be trying to get elderly people down to 7, so we're settling for 7.5, sometimes 8. But the point is that pancreas transplant, because it does turn on and turn off, it's responsive to what the glucose level is. And that's different than if you're armed with an insulin syringe or an insulin pump that's not closed loop. You have the problem that the pump doesn't turn off spontaneously. So this is probably the best one is ever going to do with any kind of therapy. And it's interesting to know that that was obtained back in the mid-1980s. We like to use intravenous glucose as a secretagogue to measure insulin secretion. And the observation here worth noting is that these data are the recipients of a transplanted pancreas. This green area are normal controls. The transplanted pancreas briskly releases insulin just as the normal pancreas does in a normal person, and is the same die-away curve that you see. So this organ, transplanted in the pelvis, not really innervated neurally by the brain like a normal pancreas is performing wonderfully. It just seems to do the right things, both time-wise, phasic release, and it was a thing of beauty to watch when we first got the data back. Glucagon secretion is a very critical hormone to people being able to live. People don't think about the glucagon as much as they do insulin, but the way you test glucagon secretion is oftentimes with a hypoglycemic clamp. So you lower the glucose intentionally, and you see what kind of glucagon response the recipient will have. Here you have a comparison of glucagon responses during a hypoglycemic clamp, which just means we're infusing insulin and purposely lowering the glucose level in the subject, and then we track how quickly and to what magnitude glucagon is released. So here are the controls in red, pancreas transplant recipients in green, kidney transplant alone in purple, and these are people with type 1 diabetes mellitus, non-transplanted. A massive difference between a puny glucagon response in this case and a perfectly normal glucagon response after pancreas transplantation. And again, it's important to note this is a donated pancreas put in the pelvis, period. There's no neural connections. We have learned that the vagal connections are very important to regulation of the alpha cell, but it seems like it doesn't make much difference, or at least not as much as we had thought. Mike Maurer was mentioned earlier today. He's a nephrologist at the University of Minnesota. Mike is an incredibly patient person. With the recipients that David had transplanted in those days, Mike kept bringing back people to get kidney biopsies. So this was published in the New England Journal of Medicine in 1998. Here's a pre-transplant kidney biopsy. And for the nephrologists in the audience, you'll recognize this is a very abnormal looking biopsy. Still abnormal 5 years post-transplant, but 10 years post-transplant, all that glomerular matrix is cleaned up. So it's a great message to know that kidney disease and type 1 diabetes is reversible. It really incentivizes folks to normalize the glucose level as much as possible in type 1 diabetes independent of transplantation, because it tells you that kidney disease is reversible. Until this time, that was never noted. So this is an example of, if you look around after you do the transplants and start making measurements and clinical observations, you make other discoveries. This is from William Kennedy, also at the University of Minnesota. He was mentioned earlier today. This was an amazing observation. Here's a comparison after pancreas transplant compared to type 1 diabetes mellitus as controls. This is the inexorable decrease in neural function, motor, and sensory that you see with people with diabetes. But for those who are successfully transplanted in yellow, it arrests that continuous decline in neural function, both conduction. Questionable whether these are significant, but it is significant that you can reverse neural abnormalities if you control the glucose level after successful pancreas transplantation. Again, an encouragement to people who take care of people with diabetes without transplants. It's worth managing the glucose, getting the hemoglobin A1C as low as you safely can. And here I'll hypothetically mention that within this group is a subgroup of people with autonomic nervous system dysfunction. They're the people that you may be familiar with who get hypoglycemia, who have gastric motility problems, who cannot maintain the blood pressure. They act as though they're volume depleted. Those people are on track that says 50% of them will be dead in 5 years. So if you have a type 1 diabetic patient with autonomic nervous system dysfunction, they're on a path to sudden death. That's the group that I would say one should champion champion solitary single pancreas transplantation alone in, because they have a death sentence awaiting them. And when I see patients like that in clinical practice, I refer them immediately to the University of Minnesota to get a single pancreas by itself, not kidney, just pancreas, because they're having a difficult time surviving. How about the eyes? We mentioned the eyes earlier this morning. So these are 3-year post-transplant fundus findings and required laser therapy. The thing to focus on is the green color. This is simultaneous pancreas kidney, and this is kidney alone transplantation. So when you add a pancreas to a kidney transplant, you do much better in terms of maintenance of fundus. In terms of need for laser therapy, this is the combined organ. This is kidney alone. So you can see there's a difference when you control the glucose level in terms of eye findings. And these are fairly good numbers, 43 and 45. So to continue that theme, how about regression of atherosclerotic plaque? I would not have thought this would have been the findings, but it is these are the findings, that there's actual regression of plaque. So where you want to be after these kind of surgeries are where the green is, not where the blue is. So if after pancreas transplantation, but it's not lost, you get this actual improvement below the line here on the amount of plaque. This is in the coronary artery, and the control group is here. These are people who were transplanted, but they lost the pancreas. So again, complications are reversible, complications are preventable. How about islet transplantation? So here we got to think about both allo and auto islet transplants. So it'll be the same general theme of looking at success rates, beta cell function, and alpha cell function. This is a schema of one was shown earlier today. It just points out that both for allo and auto, you go through the same procedure. You have to isolate the islets, and the idea is to separate out exocrine fragments, try to purify the islets. In the case of allo-transplantation, not nearly so necessary with auto-transplantation. But in any event, you get the islets, and then you put a kind of a trocar transcutaneously in the liver, through which you can thread a cannula, and then there's an IV bag, and you just dribble in the islets. Catheter is retrograde in the hepatic portal vein, and then the blood flow just chases all the islets into the radicals of the liver. And you wind up with this, with islets in the sinusoids. And so we should look at some of those data. Now, when this initially happened, this is the so-called the Edmonton Protocol. And what they did in Edmonton is they basically did the same kind of islet transplants that have been done before with allos, but they did two things majorly different. They allowed themselves to give not just 1, but 2, and sometimes 3 infusions over the course of a year. And they avoided the use of glucocorticoids as an immunosuppressant. Glucocorticoids are known to be toxic to beta cells, so that was a wise choice. And the game was, they were playing is how many times we'll get enough islets in until we finally get successful. We're not going to limit ourselves just to 1 islet transplant. After the first year, there was general euphoria because these were 7 out of 7 patients at this point, but had never been seen before. It was 7 sequential patients with normal glycemia a year after islet transplantation. These are type 1 diabetic patients. But with time, things deteriorated, so much so that 15% of the patients just totally failed. 77% were called partially successful because you could still measure C-peptide, and it had to be coming from the intrahepatic islets because their own, of course, pancreases were not secreting C-peptide. 8% had complete success. This was a little bit depressing because this was about 2001, as I believe it. 5 years later, things didn't look so good anymore. But, people rallied around and different centers got involved. Things did get better over time. So now the picture looks better. Currently, the last report I saw was the CIT-07 a couple of years ago. Insulin independence, it was now 58% out with time. C-peptide positivity, 92%. Again, this is solid proof that the islets are working, because remember, the native islets are not functional. In severe hypoglycemia, which is the primary indicator to have the islet transplant, was down to less than 10%. Presumably, all of these patients who got islet transplants were all experienced severe hypoglycemia. So this looks like that's been, quotes, cured, but there's one caveat. For example, here's the Bernard Herring published this in Diabetes Care. Here was baseline percent of patients getting severe hypoglycemia, 100%, but after the successful islet transplant, the allo-transplant, it's down to less than, probably negligible, less than 10%. Now, the caveat is this. The reason people with type 1 diabetes get hypoglycemia is they take insulin. It's not part of the disease. So if you're not injecting insulin, you don't get hypoglycemic. And the question remains, is the reason these people are not getting hypoglycemic because the islets are wonderful, or is the doctors are not giving them insulin anymore? So think about that, and I'll show you some data in a minute to help you think about it. Here it is here. So what we did, this is Barry Patey is an ex-fellow of mine. We decided to do the hypoglycemic clamp in islet transplant recipients to address the question whether alpha cell function was normalized. Was that the reason that people were no longer getting hypoglycemic? And the answer was a little unexpected, but it is anyway. So if there's a glucagon response, this is blue line, these are the normal controls. The red line are people with type 1 diabetes non-transplanted, total absence of glucagon secretion, and we knew that before. What we didn't expect is the transplant recipients also had a not impressive of any glucagon secretion during hypoglycemia, which caused us to scratch our head because we knew the alpha cells were in the islets that were transplanted, and we knew, I'm not going to show you the data, but we knew that because we could give those patients arginine, we could elicit glucagon secretion from the transplanted islets. So the islets were making glucagon, but they were not behaving normally during hypoglycemia. And I'll say a little bit more on that in just a little bit. We don't really know, we can't say much about chronic complications following successful allo-islet transplants. There have been a couple of reports saying some of the secondary complications are reversed or partially reversed, but it hasn't been studied completely enough to really tell you that's the gospel truth. I think that's the way it's going to go. It should. If you're normalizing the glucose levels, we know from pancreas transplant data, the complications should improve or reverse. But I think we'll need more studies to get there. So let's do auto-islet transplant. Now, Melina is going to follow me and discuss this issue in children and some adults, but I just wanted to be sure you're clear about who gets to get auto-islets, who gets to be pancreatectomized for chronic pancreatitis and undergo auto-islet transplants. And they had to be chronic pancreatitis refractory to medical treatment and endoscopic interventions. And I think it's a consensus now that the endoscopic interventions basically are not worth a great deal. People have been stented time after time after time after time. It just doesn't work. Medical treatment is not wonderful. So the patients of Minnesota who meet this criteria have got to first base. Narcotic dependence and significantly impaired quality of life is a must-be, but it's almost a no-brainer. Because if you've had chronic pancreatitis for over 2 years, most likely you're going to be narcotic dependent, and your quality of life can be really miserable in terms of getting to work, child care, one tragedy after another. You have to lack medical or psychosocial contraindications, no-brainer. And you have to be non-diabetic or C-peptide positive. So the trade-off here is some people who have chronic pancreatitis may be diagnosed as diabetics, mild if you do a glucose tolerance test. They have to understand that they may become blatantly diabetic if we don't get enough islets from their pancreas to put back in the liver. And the trade-off really is you have to be willing to accept the risk of diabetes for pain relief. this again is a no-brainer for these people. The people who come to Minnesota, and I'm speaking primarily of Minnesota, but I guess generalizable, are just miserable. You saw the picture of the young lady from Arizona. That's perfectly typical, you know. Nice-looking person, losing weight, getting depressed, on narcotics. It's just a miserable life. So what do we know about the success of this? You can't really deal with success rates with auto-islets like you can a whole pancreas, because you know what you're giving the patient when you give them a whole donor pancreas. When you do allo-transplantation, all you can give them back is what you get. So as Bala pointed out, you don't always get a good yield. So the only way to really analyze this, and I really recommend this article by David Sutherland in JACS 2012. It's just a ton of really wonderful mineable data. So if you want to write anything down at all, write that reference. If you get from the auto-islet procedure less than 2,500 islet equivalents per kilogram, those are these data. If it's 2,500 to 5,000, you get these kind of responses. And if it's greater than 5,000, which is really basically about a third of a pancreas, you get really great responses. So what are these responses? These are C-peptide positivity, so it's measurable C-peptide levels, and a hemoglobin A1C level of less than 7%, not taking insulin. So really good control. Well, you can see the more islets you get, the better results that you get. So it's a quantifiable thing. It's not quite a dose-response curve, but the message is you want to do this operation for people when they have a lot of good islets. You do not want to wait 10 or 15 years when they destroyed half their islets and then think about doing a pancreatectomy and then think about doing auto-islet transplants. I think this is a great argument for doing preemptive total pancreatectomy in people with chronic pancreatitis and big-time pain. I don't see any point in doing partial snipping away at the pancreas, hoping to get an area that's involved when historically, you know, there's going to be another area involved pretty soon. And I'd like to have that debate with John if he's here. He's back to clinic, okay. But I think it's a great discussion to have because, again, as Reiner pointed out, I think, maybe subliminally, there is resistance to exception to this procedure in the medical community. And I don't get it. I don't get why it's not in Williams' textbooks of endocrinology. I don't know why up until a few years ago it wasn't even in textbooks of transplantation. There's a strange feeling that doctors get about taking out somebody's pancreas. Not surgeons, obviously, but other doctors. And we just got to get over this because there's a lot of people suffering with chronic pancreatitis. They don't need to. I think practically speaking, if you're going to consider this procedure, do it as soon as it's evident this is going to be chronic, unrelenting pancreatitis. That's very painful. Why wait? Insulin secretion data from the auto-islet transplant looks something like this. These are simply measurements of beta cell function. I won't go into what all the alphabet soup makes, but this is a normal response, control response. This is a control response of a different way of measuring insulin. This is what you get from recipients of auto-islets, not quite as tall as the blue bar, and this is what you get from auto-islet recipients, not as tall as the blue bar. But if you correct those values for the number of islets you've transplanted, because you know that, they've been counted before you put them in the liver, and just divide the number you get by that, then you get the green bars. Key thing is this is this response per islet number, where the control response is assumed to be 1 million. A million islets is what we assume is in the pancreas. It's very encouraging. This is actually greater, although not statistically greater than normal, and this is comparably normal. So I think this presents the case. If you know the number of islets, and you measure C-peptide or insulin, and then divide that response by the number of islets, you should expect a normal response, in quotes. And if you turn that argument around, you do that response, you have the individual data for an individual, you can extrapolate and make a guesstimate of how many islets are actually alive in the transplanted liver. So the beta cell summary So both baseline and glucose-potentiated acute insulin responses and C-peptide responses are normally timed in these recipients. So think about that for a minute. Now you got the islet in the liver, and it's every bit as responsive in a time fashion as a normal islet in a normal pancreas. It's a pretty good accomplishment. These responses correlate very highly with the number of islets transplanted, and these are very high correlation coefficients for any kind of clinical investigation. So just think about flipping the axis and say, well, we got the response now. We ought to be able to reason backwards and figure out how many viable islets are actually in the liver. And as I showed you, when you correct that number of islets you've transplanted correct the responses by the number of islets transplanted, you find out that the responses are normal, regardless of the duration of the graft, which makes another statement. Some of these people have been transplanted for 2 years, some for as long as 15 years, and yet they're all on the same correlation coefficient slope. That's a statement that suggests a transplanted islet in the liver lives a long time. There's no slow death. They should be there long after you've placed them there. Let's turn back to the alpha cell. Turn back to hypoglycemic clamps. Because remember, I told you that the allo-islet recipients had failed glucagon secretion during this particular test. And the same is true here in the auto-islets. So this is glucagon secretion. Controls in blue, the auto-islet recipients in red. There's no response of glucagon from these intrahepatic islets, consistent with the allo-islets. But it just so happened that when surgeons do this procedure, if they have too many islets and they cannot get them all into the liver, the custom is to put them into the peritoneal cavity. That was done with 5 of these people. So now we have TPIT in hepatic plus non-hepatic at H sites, 5 patients. And this is the response that we saw. They had normal glucagon secretion to hypoglycemia. This has been reproduced now 3 or 4 times in different studies. And it makes me think, and I think other people begin thinking, is the liver the best place to be putting islets for islet transplantation? What about other sites? Well, this slide by the green bar says, well, one other site, the peritoneal cavity, can receive the islets will function, and they will have normal alpha cell function to hypoglycemia. There are many other sites one consider than the peritoneal cavity, but this is just an example of saying we should look at this much more closely. Is the liver really the smartest place to be putting islets? Even though they work for beta cells, they're obviously not working cleanly for alpha cells. I say that with confidence because what we do our control study is to give the patients, the recipients, intravenous arginine, because that's a good agonist for glucagon secretion also. In all cases, the people who don't respond, who've gotten their islets in the liver to hypoglycemia, they do respond to intravenous arginine normally. So we know the alpha cells are alive, they're functional in the liver, they just don't perceive hypoglycemia. Symptom scores are very important when you think about hypoglycemia. That's the symptoms the patients have as we purposely make them hypoglycemic. Control subjects do everything you expect them to. They get warm, they start sweating, they don't see as well, they don't think as well. We take them down to a glucose level of about 50. So that's what we call the symptom score. The symptom score to the folks who got intrahepatic islets shown in red here, the symptom score were the 5 patients that got them in the peritoneal cavity, look like this. So they have symptoms. Well, why should that be? It's because if you are recurrently hypoglycemic, you get desensitized to hypoglycemia. The people who got the islets put in their peritoneal cavity weren't getting hypoglycemic, so they did have a response now during the hypoglycemic clamp. So it's a second reason to really rethink about where we're putting islets, because if your symptom response is so bad, for here, the red ones, that's not safe. Because what that means is you can become hypoglycemic and drive a car off the road and never know what happened. So we don't want to be making people void of symptoms to hypoglycemia. It's even important in the auto-islet transplants because some of those people will start taking insulin again. As I mentioned earlier, the only way you can get hypoglycemic is by taking insulin. So if your patients are going to be at risk for taking insulin again, allo-islet or auto-islet, then is liver the best place to transplant because they will not have a protective glucagon response and they're likely not to have a good symptom response. Okay, just to finish up, the people with auto-islet transplants who tend to complain about spontaneous hypoglycemia, and many of them do when you question them closely, will tell you that when they get symptomatic hypoglycemia after auto-islet transplants, it's after exercise or a high carbohydrate meal. We've done studies of exercise tolerance on a bicycle, and on that study, the patients showed that they actually were deconditioned, surprisingly so for their age and their weight, but some of them tended to get hypoglycemic without a glucagon response. That was even more evident with this particular study. Here we're giving a mixed meal loaded with radioisotopes, and I'm not going to show you the isotope data, but I want to show you some of the hormonal data. Look what's happening to the glucose level in the recipients compared to the normal controls. They're getting twice as hyperglycemic with a fixed glucose load, and then they dip down below normal. So they get this huge increase and then this huge fall. If you look at their insulin data, well, this is just another illustration of that. At the end of the curve at the 5 hours, this is where the normals were. The people who were auto-islet recipients were falling down appreciably down to minus 60 milligrams per deciliter. So that was a serious fall. Here's the insulin responses in the same people. The normal controls here are shown in the open circles. That's what it should look like for the insulin response. The recipients had a lesser response. Remember, they don't have as many islets as the normal control, so you wouldn't expect them to be as great. But if you corrected that response for the number of islets they got, you got a huge response, which would be more appropriate for the kind of hyperglycemia the patients are getting. I mean, those islets are responding to the glucose level. Same for C-peptide. So you correct the C-peptide response for the number of islets received, it's greater than it should be for the given glucose level. What was glucagon doing all this time? It was doing nothing. So once again, these people had their islets in the liver. They're getting hyperglycemic with reflexive hypoglycemic at the 5th hour. Insulin's going way up and C-peptide is going way up. Glucagon's doing nothing. This is what patients complain about. I get hypoglycemic after a high carbohydrate meal. I get hypoglycemic after severe, high degrees of exercise. So I think this explains why this gets so low. So in summary for that, this large increase and decrease in postprandial glucose occurs in this sort of glucose tolerance test. There are absent glucagon responses at that time. And these are just the radioisotopic data you can't even see and you probably don't want to hear about. But we measured insulin resistance, endogenous glucose production, and glucose sensitivity. There are no differences there. So the only differences we could find was yes, they get hypoglycemic. No, they do not secrete glucagon. So here's the alpha cell summary. I don't have to read it for you. I just said it again. Remember, these are all controlled by arginine, so we know arginine is our gold standard. If we can get glucagon out of an alpha cell with arginine, why can't we with hypoglycemia? And just to reiterate the point I've been making ad nauseum here, to the surgeons is think about non-hepatic sites. There's no reason not to try it. It works. I know it works because if it didn't work, patients wouldn't be normal glycemic, and they secrete insulin. So the peritoneum, which has been avoided for a long time because people thought vasculature wouldn't be enough to support islets, simply not true. It really will. So I think this is the last slide. So pancreas transplantation, kidney transplantation, if you can have transplanted a kidney for a diabetic, give them a new pancreas too. There should be no reason not to do that, especially if you have an autonomic nervous system insufficiency. Like I said, figure to remember, 50% of those people will be dead once they're diagnosed, within 5 years of the diagnosis. Allo-islet hypoglycemia is a indication, but just remember the reason they get hypoglycemic is because they're taking insulin. Just because there's no more hypoglycemia after allo-islet transplantation doesn't mean the islet has done the trick. What's done the trick is people are not giving them insulin anymore. And of course, auto-islet transplantation, I think, is absolutely indicated in chronic, unrelentingly painful pancreatitis after 2 years. I mean, might as well get with it while the pancreas is healthy, and you can get it out with ease and get a much higher islet yield. And David Sutherland was mentioned. I just talked to him on the telephone. So David's pretty perky today, so that's good to hear. And there are a lot of people who helped out. Melina has been a huge help. And some of the earlier work I did in conjunction with James Shapiro, Eddie Ryan, and Bray Patey. So that's it from Seattle.
So Dr. Robertson will have to leave early. I think we'll make an exception, and if there are any questions, because I mean this is really fascinating material, the differences between pancreas allo, islet allo, islet auto transplants. Paul, there are actually a good number of medical students in the audience. Can you explain to them very briefly what a hypoglycemic clamp is? Because I'm sure, I mean, they understand what arginine stimulation, glucagon stimulation is, but what is the hypoglycemic clamp? Robert, can we have sound?
Well, I am an endocrinologist. I needed a surgeon to point that out to me. So a clamp study is when you try to get a glucose level at a certain level, and you do this by infusing glucose first, and then maybe 5 or 10 minutes later, after you've elevated the glucose level, you infuse insulin to try to bring it back to a given level. And you can do this by measuring glucose levels every 5 minutes. That's a simple thing to do. There are hyperglycemic clamps. So when you want to let the glucose level rise up to, say, a level of 300, then you start infusing the insulin to get it to a rest there. So you want to study what the patient's behavior is like at a hyperglycemic level, and you clamp it, so to speak, by simultaneously infusing glucose and insulin. Hypoglycemic clamp is the same thing, but it's just the opposite. You infuse insulin first, you get the glucose going down, and then you try to break it by infusing glucose. And we call that a stepped clamp. Usually we do it at 90, then 80, then 70, then 60, then 50, we stop there. And that's is a great way to measure glucagon responses, because it gives you responsivity, it gives you a magnitude, sensitivity to the hypoglycemia, so all kind of neat parameters that you can measure.
One question that came up, obviously, it appears that the liver is toxic to alpha cells. Because the beta cells, I mean, you do see a response. Alpha cells, you don't see the response. You know, I mean, I just wonder, I mean, does that make any sense? Why?
So let me save you from yourself, Ryder.
Huh?
Let me save you from yourself. The alpha cells in the liver are perfectly normal. They do release glucagon to arginine. Mm-hmm. So they're not a victim of toxicity. But what you're asking is a great question. So that's why we did the experiments, and we could do these in rats. And that was to go through this hypoglycemic clamp business. But do it in rats, it's a complicated model, but do it in rats and see the lack of glucagon response until we fasted them for 48 to 72 hours and depleted the liver of glycogen. Mm-hmm. When the liver was depleted of glycogen, the islets and the rat's liver released glucagon perfectly. Mm-hmm. So I think the best guess that I have is that if you have a lot of glycogen in your liver and you put islets in the liver has all that glycogen, they're being fooled because the glycogen keeps breaking down all the time and bathes the intrahepatic alpha cells with glucose. So the alpha cells in the liver are perfectly happy. They don't think they have to go to work because there's lots of glucose around telling them not to secrete glucagon. But if you deplete the liver of glycogen, those intrahepatic islets are perfectly normal. So there's no toxicity. Okay. It's just a matter of understanding that glycogen is being made and bathing intrahepatic islets all the time, especially if you get slightly hypoglycemic, because that turns on glycogenolysis. So I think it's a very functional, physiological, wonderful thing, just not very useful clinically.
Comment, Bernard, from the allo perspective?
Among the many things that you outlined, the susceptibility of auto-islet recipients to hypoglycemia compared with allo-islet recipients. So I think it is the same implantation site, but there must be important differences in GI reconstruction that make patients very susceptible to hypoglycemia after total pancreatectomy. Because in allo-islet recipients, at least clinically, there is no hypoglycemia-related problem as opposed to auto-islet recipients. I think this works, yeah.
Well, you know, Bernard is a very logical guy. He's an endocrinologist, too. The thing is that one of the major differences between allos and autos is the autos get a Roux-en-Y. And that just completely disrupts the architecture. I mean, I don't know what's happening to the vagal nerves after surgeons get through with their Roux-en-Y, but I'm sure that has something to do with the differences between the two patient groups. And the other major difference is, and I'll just hang on to this, is that the successful allos don't go back on insulin. It would be an interesting study to repeat that again. I mean, we did this with earlier with Bray Patey's study showing the hypoglycemia clamp in allo recipients, some of the first ones that James did. They had no glucagon response to speak of. Now, there have been a couple of publications suggesting that there is a glucagon response, but that's not the same brisk glucagon response that you expect to see in normal subjects. So Mike Rickles and I have this argument, but it's not an argument, it's a friendly discussion. You know, he'll say, oh, no, there are alpha cells that are releasing glucagon. Well, yes, Michael, they are. But when Michael does his experiment, he does it in such a way that there's an antecedent epinephrine response before he sees the glucagon response. Epinephrine is a secretagogue for glucagon. So, I mean, I hate to get tedious about this, but if you reason your way through this, the alpha cell doesn't get away scot-free. It'll be compromised. If enough of the allo recipients start taking heavy doses of insulin, I think you're going to encounter people who don't have a glucagon response and who have decreased symptom awareness. But fortunately, the allos that are, you know, they're successful, so they don't have to undergo that test.
So, Paul, we have a few patients in whom we do not use a Roux-en-Y. We just bring the jejunum all the way up, and then, I mean, just continues in continuity. So it would be interesting to see in those patients if there is a difference to the one that have a Roux-en-Y. Because, I mean, we all have observed, obviously, patients after islet auto-transplants to have hypoglycemic episodes. But I think it would be interesting because we have done it in both ways. We have taken only one. We have done it with a Roux-en-Y and without the Roux-en-Y, and we have a few patients that actually have two Roux-en-Ys, where we use one Roux-en-Y on the duodenal gastric side and one on the liver side. So maybe what we'll do is we'll send you some samples of these patients, and we'll have Dr. Banerjee work on it, because, I mean, this is fascinating.
Well, I think what you should do, because, you know, I'm not going to keep doing this work forever, right? I'm retired. Right. So we need to train more endocrinologists to get involved here in Brooklyn, and you should do those studies here.
Yeah. Well, I'm just asking out of curiosity, how much work has been done in bariatric surgery in regards to glucagon responses? Because, I mean, there you're obviously, I mean, dealing with very long Roux-en-Ys, and it would be interesting, and I'm not sure if there's even any literature that exists in that regard.
Well, there's a burgeoning literature of hypoglycemia in bariatric surgery patients. It's just becoming recognized now. And I think it's going to be a good counterpart to what we're seeing with the auto-islet recipients. Because during their surgery, again, Roux-en-Y is often part of the thing. Different kinds of bariatric surgery, I guess. I'm not sure which ones are popular now. But if you start doing major surgery in that arena, you'll be doing things that interrupt vagal blood flow, vagal neural flow.
Mm-hmm. Any other questions for Dr. Robertson? If not, thank you very much, Paul, for